patient has severe insulin deficit, is it better to give insulin sensitizer or to give insulin secretagogues or to start with insulin because he has severe insulin deficit? But this classification is important for two things. For choice the proper anti-diabetic drugs, the second for know the mortality and morbidity. Method in severe insulin deficient diabetes, there is increased risk of retinopathy and neuropathy. The second type is called severe insulin resistant diabetes. There is insulin resistance, there is obesity, and there is increasing risk of neuropathy. So which meter of drug in this case is to give insulin sensitizer, not insulin secretagogues. And the third one, which accounts for 3% of the case, is called mild obese related diabetes. You have to give a drug that increase body weight. You have to avoid the drug that increase the body weight. You have to give a drugs that decrease weight. The third one is, which accounts for 39%, is called mild age-related diabetes. It is less onset and there is low risk of complication. So it is age-related. In old age usually has a high risk of hypoglycemia. So you have to avoid the oral anti-diabetic drugs that cause hypoglycemia. So what is the treatment goal? ما هو الهدف التريتمنت according to the HbA1c؟ يعني مثلا مع patient أو doctors أو ophthalmologist doctors or cardiologist doctor and as cardiologist doctor, they refer the patient, yeah doctor, the patient hemoglobin A1c is 8. You have to control. You have to reduce the A1c. If you reduce A1c, this patient is at a risk. But the A1c should be regulated according to the patient's situation. For example, if the patient has a high risk of hypoglycemia, the A1c should be kept high. If the patient has a long duration of diabetes, so the A1c should be kept high, above 7. Up to 8. A patient with life expectancy is short life expectancy, so the A1c should be kept in high level, above 7. A patient with important comorbidity, like retinopathy or nephropathy or neuropathy, so the A1c should be kept in a high level, above 8, usually above 7.5 to 8. So the A1c should be regulated according to the patient situation. We do not strict in the A1c between 6.5 to 7. No, it should be regulated according to the patient situation. So what's the lifestyle? As you know, the nutrition, you have to give the patient a carbohydrate, usually carbohydrate of a complex carbohydrate, carbohydrate of high fiber content, and have carbohydrate of low glycemic index. You have to ask the patient to do a regular physical activity. You have to ask the patient to sleep for more than 7 to 8 hours and for smoking cessation. So there are two types of anti-diabetic drugs, whether oral or injectable. We start with insulin in the early diagnosis type 2 diabetes. Those with entry HbA1c more than 9 and the patient is severely symptomatic, is dehydration and has polyuria and polydipsia. Some doctor, they start with insulin in early diagnosed type 2 diabetes in order to induce a beta cell rest. Otherwise, you have to start with oral anti-diabetic drugs. Which this type of drugs, the available drug, as you know, alpha-glucosidase inhibitor, poly-VC-LAMs, and this is a bile acid sequestrating drug. Bromocriptine usually increase dopamine secretion. They found dopamine suppress the hepatic glucose production and increase insulin sensitivity. Glycogen like peptide 1 receptor agonist dipeptidyl peptidase type 4 inhibitor, sulfonamide and big-glutinide, metformin, insulin, and thiazolidinedione, and sodium glucose linked transporter 2 inhibitors. So this is the summarize the major oral anti-diabetic drugs, their efficacy and their side effect and their benefit. So if we start with metformin, metformin usually acts as the liver by enhancing insulin sensitivity. أهم حاجة في الميتفورمين أنه it has low risk of hypoglycemia, it induces weight loss. ثالث حاجة إنه it has a cardiovascular benefit. The next drug which is important بعد الميتفورمين هو sodium glucose linked transporter 2 inhibitor. برضو these drugs have low risk of hypoglycemia, it enhances induction of weight loss, and the risk of hypoglycemia is low. The effect in atherosclerotic cardiovascular disease and heart failure is yes. It reduces the all-over major adverse cardiovascular mortality and the risk of heart failure and the risk of hospitalizing patients with heart failures. The third one is glycogen-like peptide 1. This is the most effective drug in reducing body weight, and also it is very effective in preventing atherosclerotic coronary vascular